Good evening, everyone, and welcome to the fourth AFWG ANSMIG webinar for the year. This is a presentation based on the two societies, and it's termed Fungal Frontiers in the Asia Pacific. Tonight, we are delighted to hold Fungus Fights Back, and we have a case presentation first, followed by an expert panel discussion, and then two lit reviews of sorts, and there'll be a general Q&A. So now I have great pleasure in introducing Dr. Pao-Yu Chen, who is an attending physician in infectious diseases at the Department of Internal Medicine at the National Taiwan University Hospital. So over to you, Dr. Chen, and we're looking forward to your case. Thank you.
Thank you. I'm going to share my slide first. Can you see my slide? Yes, okay.
Yes.
Thanks. Good evening, everyone. It's my honor to be invited to present a challenging case and review the related topic in the literature. And this is a 33-year-old woman presenting to the emergency department with febrile neutropenia and a dry cough for 2 days. Her underlying disease is early precursor B-cell acute lymphoblastic leukemia in relapse and refractory status. He was undertaking inotuzumab ozogamicin is an monoclonal antibody drug conjugate, which bridged her to allogeneic hematopoietic stem cell transplantations. Because she had persistent fever, she was admitted and received broad-spectrum antibiotics, including piptazole and meropenem. Her cough persists as well, but there were no relevant microbiology results. On day 6 of hospitalization, we can see there were some heaviness at right upper lobe. And in the meantime, the gut hormone antigen collected on day 3 was reported on day 6, which showed 1.12. So we arranged the chest CT. We can see there was a subpleural consolidation surrounding hollow sign on right upper lobe. So this was a typical host with prolonged neutropenia and typical clinical feature, including airway symptom and the CT findings. So we initiate antifungal agent. But on day 7, we can see the GM testing return to normal, even at the time of initiation of antifungal agent. And in the following time, we didn't have any positive culture for fungi, including Aspergillus species. But we treat this patient as probable invasive pulmonary aspergillosis. And we choose isavuconazole for her fungal infection. She also received monoclonal antibody to bridge stem cell transplant. And before transplantation, the hematologist arranged a PET scan to evaluate her malignancy extent. We can see that in the PET scan, there are many malignant lymph nodes shown in the PET scan at different body sites. But for the pulmonary aspergillosis, the intensity seems declining, suggesting pulmonary aspergillosis was controlled by isavuconazole. So on day hospitalization, day 82, the patient received allogeneic hematopoietic stem cell transplantation with conditioning regimen consisting of total body irradiation, cyclophosphamide, and anti-cytoglobulin. The patient remained agreeable until day 6 after stem cell transplant, when she had a peyroniecia on her right first toe. And on that night, fever developed. So the primary care team initiated safety workup, including blood culture. They also started label processing for fever neutropenia with peyroniecia. But fever persisted in the following 2 days. Meanwhile, there are some variable sized papules developed on her hand, trunks, forelimbs, and feet. We can see the size are variable. Like this one is as small as 1 milliliter in diameter, but the other one is as large as 5 milliliter in diameter. And some of them have central necrosis. So in summary, this is an allogenic stem cell transplant recipient receiving parental isavuconazole for prior invasive pulmonary aspergillosis, presenting with fever neutropenia and skin manifestation in pre-engraftment stage. So what is the most likely diagnosis for her? And there are 5 choices. I think we can stop here to have a short discussion for this case. Are there any questions for me?
Perhaps we can ask the panel, Bunhock. What do you think?
Yes, of course.
Okay.
Yes, let's ask the panel.
So, Caitlin or Yee-Chun or
Jasmine, anybody?
Jasmine?
Maybe I'll go first. The first person who goes first probably have it the easiest. Um, I think there are a few things that come to mind. First is the pre-transplantation period, and the next is the post-transplantation period with all these cutaneous nodules. I was just wondering at the start if there were a few processes going on at the first onset of febrile neutropenia with raised galactomannan and pulmonary changes. With the drop in galactomannan levels in response to isavuconazole, perhaps it could have been aspergillus at the time, and on long-term IV isavuconazole therapy, now with breakthrough cutaneous lesions and manifestations occurring around the periangle area, it makes it very suspicious for invasive fusariosis in this particular case. And I'll just pause here for the other panelists to weigh in as well.
Caitlin, what do you think?
Yes, agree. Yes, with the involvement of the nails, the skin manifestations suggest dissemination, so adventitious spread. And just having looked up the mycology Adelaide website with MICs, fusarium tends to have higher MICs and could well have broken through in this context.
Yes.
I'm Yee-Chun Chen. Thank you for 2 panels comment. In addition to fusariosis, we need to think about the azole-resistant candida, the septic emboli. However, the skin lesion is quite different. So I think it's very important, and this is a reason why we present this case. So please be careful regarding the skin presentation. It's a very important hint.
May I ask a question of the panelists? What about Scedosporium or Lamentaspora infection? What is your opinion?
We have no experience. You are expert.
No, no means an expert. I mean, it's got skin and yeah. I'm sure Dr. Chen is about to give us the answer, so I shouldn't preempt it. But if I were to see the yes,
I
if
can
I
have a
were
go.
okay,
Yeah.
Jasmine.
I think it also depends on the region that you're from and the epidemiology of fungal infections in the region. I think in our region, Scedosporium and Lammentospora don't feature so high on our list. Fusarium would be the first on our list. But I agree that we should keep an open mind, and at the end of the day, a tissue biopsy would be important because we can get caught up and it could be atypical presentation of other opportunistic pathogens, and that's not where we want to get caught up with. Yeah.
Thank you, Jasmine. I think we should invite Dr. Pao-Yu Chen to continue with his case.
Okay. And for this patient, what will you do for the presentation? First, we will do fever workup, especially blood culture for fungi. And the second, maybe we have to consult the dermatologist for skin biopsy for the tissue proof and microscopic workup, including direct microscopy exam and fungal culture. Third, maybe we can use a CT scan to evaluate the disease extent. As well as we know that breakthrough infection, the drug concentration is also important. So maybe we can check isavuconazole trough concentration. Since this is a breakthrough infection, so we may adjust the current antifungal agent to another anti-mold therapy or combination therapy. Are there any intervention that I need to do, or do you agree all the intervention that I will do?
Yeah, we can surely choose more than one option, right?
Yeah, this is about, yeah, you can choose all of them.
I would like to put in a vote for blood cultures and offer an acronym that I was taught very early on of FACS for molds that will come up in a blood culture. It stands for Fusarium, Acremonium, Cocci, and Scedosporium, which now also would be Lammentospora, so it doesn't work so well as an acronym. But those would be some of the important differentials as well in this context.
Yes.
Well,
Yes,
let's
how about
Skin biopsy is quite important, I think.
I think evaluating, usually it's a combination of all of the above. I think evaluating the extent of the disease is also useful. I think she has very disseminated infection, and as the case evolves, we want to know whether the therapy we institute is improving or worsening, and that will give us a sense of how she's doing as well.
yes?
Isavuconazole concentrations may not be so easily available, but I would agree this is a situation where having a trough may help, although we really shouldn't wait for that to change the fungal agent. That's my feel. Yee-Chun or Caitlin, you think so?
Yeah, I need more opinion from yours because regarding the antifungal, how to modify the antifungal. How about your suggestion?
We should ask the panelists.
May I ask the panel so this is a guy with presumed aspergillosis, so the empiric treatment and isavuconazole was chosen. Was there a particular reason for isavuconazole as opposed to Vori or Posa, or what is standard in your practice?
Yeah, in my institute, we use voriconazole of isavuconazole as the first line for invasive aspergillosis. If the patient have abnormal liver function or his ongoing treatment plan have many drug-drug interaction with azoles, we may choose isavuconazole as the first line rather than a voriconazole. Otherwise, we will use voriconazole as the first line. And sometimes when the patient develop some side effect due to voriconazole, then we will switch to isavuconazole. Because for this patient, the hematologist told us that her plan is receiving allogeneic hematopoietic stem cell transplantation, which will have many drug-drug interaction after transplantation. So we started with isavuconazole for this patient.
Thank you.
I think if I'm suspecting invasive fusariosis, and it's a disseminated infection, and we know from experience that most of the although there are no defined breakpoints for isavuconazole invasive fusariosis, the drug of choice in the disseminated infection in our practice is still the combination IV ambisome and voriconazole. Yeah.
Thank you.
Well, thank you. Let's proceed with the case.
Okay. Yep. The panelists tell us that we need to open-minded to this case, but there are some characteristics of skin manifestation due to invasive fusariosis. Besides, based on the local epidemiology in Taiwan, invasive fusariosis is more common compared to schistosporosis or Lomentospora infection. So I have a quick review about recommendation for diagnostic for fusariosis proposed by ECNM in 2021. All the diagnosis approach has been discussed in the previous slide. In addition, the guideline recommended that once fusarium is isolated, we need to use PCR or MANTOF for the fusarium species identification. And if available, we can perform antifungal stability testing to guide antifungal therapy for invasive fusariosis. And for the treatment, as Dr. Jasmine Chung mentioned, voriconazole or liposomal amphotericin B monotherapy is recommended, as well as combination of these two antifungal agents. And some auxiliary therapies are recommended, including source control and the recovery of neutrophil, including administration of GCS or granulocyte infusion. In this slide, I will show the diagnostic and the treatment response for this patient. Because we know she had skin manifestation on day 8 after transplantation with high fever, we consult the dermatologist for the skin biopsy. In the same time, we switch antifungal agent to liposomal amphotericin B at a dose of 5 milligrams per kilo per day. 2 days later, the blood culture on day 6 reported positive to SET. And for the tissue pathology finding were suggestive of angio-invasive fungal infection, although the tissue culture was negative. Based on these findings and the local epidemiology, invasive fusariosis is very highly suspected. So we add the second antifungal agent, voriconazole, combined with liposomal amphotericin B. Finally, the mode identified from the blood culture, isolated from blood culture, were identified as fusarium solani, which were also isolated from the sputum and the skin pus. And we can see that the fever persisted, as well as the sequential CRP level showed an increasing trend. For the follow-up blood culture, the time to positivity becomes shortening. We were very worried about the efficacy of 2 drug combination in transplantation. So we decided to add the third antifungal agent, test for function for this patient. And for the primary care hematologist, he administered GCSF when febrile neutropenia developed. And as we can see that under the triple combination, the fever curve seems improved and the CRP level declines. We can also notice that the white blood cell count returned to normal range to the current treatment response. But during the sequential follow-up, all serum galactomannan antigen were all negative, which were below 0.5. We also arranged CT scan to evaluate disease extent on day 20 after transplant. The chest CT showed ill-defined nodular opacity at bilateral round, which was indicated by yellow arrowhead. And the head CT showed paranasal sinusitis and a small abscess formation, 8 milliliter in diameter within left masseter muscle, shown by red arrowhead. We also consulted the surgeon for the debridement for the muscle abscess, but the size is very small, so the surgeon advocates to keep antifungal combination rather than surgery. And for this nodular lesion in the lung, we suspect this attribute to septic emboli. So we also arranged cardiac echo, but the echo didn't show any vegetation on the cardiac valve. On the next day, we arranged a brain MRI to test whether there are any CNS involvement. And we can see there are 2 tiny spots of abnormal bright up lesion on DWI and dark lesion on ADC. Both of these lesions suggest meningitis presentation. So this patient had disseminated infection involved lung, skin, muscles, and the CNS. So we titrate liposomal amphotericin B doses up to 10 milligram per kilo per day. Unfortunately, 4 days later, the patient had blood lesion. So we consulted ophthalmologist as soon as possible. The local findings showed that there was choroidal retinitis at her left eye. And for her right eye, the vitreous had opacity and strain. And in the fundus, there are 2 subretinal abscesses with some exudative material, as well as scattered retinal hemorrhage. So a diagnosis of endogenous Fusarium endophthalmitis was made. So the consulted ophthalmologist arranged AC and the vitreous therapy, followed by intravitreal injection of voriconazole to her right eye. Of note, the fungal culture from CSF, vitreous, and the nasal swab were all negative, but this site are highly suspect due to invasive fusariosis. So we decided to optimize antifungal agent in the context of a patient with a remission of her hematological malignancy by transplant in the following intervention. First, we optimize liposomal amphotericin B at highest dose of 10 milligram per kilo per day. We also titrate voriconazole dosage by weekly target drug monitor. We also kept test for function for triple combination. We also coordinate ophthalmologists to arrange intravitreal injection of voriconazole to her right eye twice a week. However, the patient developed hemoptysis followed by respiratory failure on day 31. So she was intubated and transferred to ICU. 9 days later, her conscience became poor and some ICP signs developed in ICU, including bradycardia and hypertension. So we arranged brain CT as soon as possible, which showed subarachnoid hemorrhage and hemoventricle and hydrocephalus. Even though her bone marrow showed complete remission, her neurological outcome was very poor. After discussion with the patient's family, they decided palliative withdrawal and comfort care. So the patient died on day 50 after transplant. So the final diagnosis for this patient is disseminated invasive fusariosis with fungemia, cutaneous infection, pneumonia, pyomyositis, and probable meningitis, endophthalmitis, and paranasal sinusitis. And for the post-hoc analysis, we identify this fusarium as Neocospora keratoplastica, belonging to Fusarium solani species complex. And the antifungal certificate testing was performed by UCAST. The MIC of amphotericin B was 4 mg per liter, and for voriconazole, the MIC was higher than 6 mg per liter. This is my case presentation. Any comments or questions from the panelists or audience? Thank you.
Yes, thank you. Thank you, Dr. Chen. Maybe we invite the panelists for some comments.
Yes.
Oh, yeah, this is Pei-Lun. Can you hear me?
Yes, please.
Yes.
Yeah, I see from the slide this is paronychia. It is possible that cutaneous infection. Do you think it is the origin of the fusarium infection or it is not? Do any workup on the nail problem before initiate of chemotherapy?
Let's see the picture first. From my viewpoint, I cannot see specific or significant abnormality on her nail. And before chemotherapy and transplant, there were no any inflammation in paraangular area. So this is the newly developed lesion after transplant. And based on the literature, this might be one of typical presentation of invasive fusariosis, even though we didn't perform a culture from this site because there were no discharge surrounding this area, and we didn't perform biopsy at this site.
Thank you. So the culture from the skin, the pus part is taken from this area?
No, it is from the right fifth finger, fifth toe. There is one pustule like this one, and some discharge we can find. So we collect pus culture from the right fifth toe rather than this area.
Okay, thank you.
So thank you very much, Pei-Lun. May I ask the panel, this patient was galactomannan positive before transplant and was started on isavuconazole, as we know. And then later on, she was found to have fusariosis. So do you think she had fusarium from the start? Because as we know, sometimes fusariosis is a cause of a false positive galactomannan. Or do we think she had aspergillosis, pre-transplant and then got complicated by fusariosis. Maybe each of the panelists can have a go. We'll start with Caitlin.
I suppose one thing that was
okay, you first.
One thing that was reassuring was the apparent improvement on the eyes of euconazole clinically and otherwise. So that would support an alternative diagnosis and then a subsequent development of breakthrough fusariosis. It's a very sad case, and it does seem like everything that could have been done was tried. And I wonder, and this is, I know not the question that I'm being asked, but I wonder about other agents like fosmanogepix, noroloripim has variable activity because, you know, Fusarium solani really is the one that does have very high MICs, as this one did, and that we don't really have good mainstream therapies for.
That's a good question, but we can come back to it in a while. Maybe we'll ask Jasmine and then Yee-Chun this question of whether they think this was it a woman? This poor person had two different fungal infections at different times, or whether it was all fusarium from the word go.
I think I agree with Caitlin, and with the clinical improvement, I thought it could have been aspergillosis at the start. And in this group of immunocompromised hosts, co-infections are not uncommon. We have seen aspergillus with mucormycosis. It could be sequential fungal infections. I think that stood out. The fact that the hematologist had requested for a PET-CT prior to transplantation, I don't have the full report, but I'm assuming that there was clinical improvement plus absence of radiological sinister features, which brought the patient and the team to transplantation. So I think perhaps a new event developed. And like Professor Sun highlighted, I think it's important to evaluate the patient thoroughly prior to transplantation, taking a look at the nail changes. Those are hidden sites where fungus could hide before giving them the intense chemotherapy. I'm going to pause here for Prof. Chen to weigh in.
Yes, Yee-Chun, it's your turn.
I fully agree. Jasmine's as per opinion. Although we cannot exclude the possibility of the first event is due to fusarium, as we point out, the GN titer decrease before we initiate antifungal therapy. So what it means, can we exclude the possibility of aspergillosis or due to mold other than aspergillus? So this is one reason we choose for isavuconazole. However, the patient remain neutropenia or receive a sequential immunosuppression therapy. Superimposed fungal infection the possibility is possible. So very important, we need to educate patient to prevent further exposure. The big problem is fusarium is many source of exposure. So it becomes very challenging. So my question for others as per, what is optimal doses and the initial, or how to choose the optimal doses for disseminated fusariosis? This is our concern. So let's
starting dose, is it? You're asking for starting combination?
Yeah, not just combination, but also the dosage of liposomal amphotericin B. As the guideline give the dose a wide range from 3 milligram to 10 milligram. As you showed, that you can see we start from 5. We already think this is a disseminated, so we start from 5, not 3. But still, there's some extension or some involvement beyond our expectation. So this we would like to have your expert opinion regarding the optimal dose in fusariosis for liposomal amphotericin B.
Sharon, would you like to go? And then we can also ask panelists.
We should ask the panelists. I don't think there's an optimal dose, and it depends on how sick the patient is. I mean, I normally start around about 4. It's a kind of dose I'm comfortable with for a severe mold infection, and then, bump it up if I have to. I would always use combination therapy, even though the evidence isn't very robust for fusariosis, because I've never seen a patient that's not been very sick with fusariosis in this context. So I would use at least 2 antifungal drugs. I was interested in your selection of caspofungin as well. I can understand that, when the going gets rough, you need to think about all sorts of options. And, Caitlin's already mentioned the fosmanogepix, which would be my, drug of choice to try to access either through compassionate access or through one of the drug trials at the sites. If your institution is doing this trial, or there's another institution in your city that's doing the trial, I would try very hard to get the patient on that.
Yeah, thank you, Sharon. Yes, I agree. I always start with 2 also. This pair is the same. Maybe Yee-Chun or Pao-Yu could tell us why caspofungin?
Pao-Yu will review this. Yeah,
Okay, we'll review that. Maybe go on to the issue of the PET scan. Could you show that PET scan? I think you wanted to be happy, right? That you could go on with the transplant. The thing in the lung, I don't know whether I'm seeing it correctly or whether there's some problem with, but is it still quite bright? I don't know. Or is that considered less bright by the color scheme of your machine? It's quite unconventional to use this, but I think there's some data from Abby Douglas that the value of PET in invasive fungal infections in febrile neutropenia would be to help with the duration. So when the SUV values come down, you sort of know that things are settling down. Does Caitlin have any views? I thought this was a very interesting way for them to decide when to transplant. Caitlin, please.
I don't have any particular views. I think it's a reasonable thing to try in this instance. I'm interested in the other panelists' views.
Jasmine?
I think it also has got to do with resource availability, and if the PET scan were performed, it's also about comparing with prior. Personally, I feel that sometimes PET scan may also raise an alternative question. Apart from infections, it could be sites of disease. So how do we sometimes distinguish between disease versus infection? Sometimes it's a bit hard to distinguish between the two. So I think the indication for the scans has to be clear. And if it were performed, maybe what would be more useful would be serial scans and comparison, as opposed to relying on a single scan to make decisions. Yeah.
Good. That's a very good point, Jasmine. So maybe Pao-Yu or Yee-Chun can tell us, their consideration behind this PET and whether this was the first or a second.
Yeah, and for this patient, there was only one PET scan, and the indication for PET scan is mainly to determine the disease extent of hematological malignancy rather than the fungal infection. But I use this picture to highlight that the involved area of questionable invasive aspergillosis seems shrinkage compared to the first image by the CT scan, even though there are some hotspots on the infected area. This is my interpretation. So we suppose that hematologist to proceed transplant planning after this scan.
Sharon, you have any thoughts?
No, I was just going to say Abby Douglas is on, but I don't actually think I can get her to comment. She's texted me to say, not sure I have much to add. I think what's been said that is apt, and it's a very interesting finding, and it would be really good to do studies involving pets of invasive mold infections to see what the natural history and progression is like. And if we have access, immunopets as well, so that we can actually target specific fungi. But, I'm being fanciful here. We don't have access to this in Australia, not really.
Okay. Thank you. I think we should move on. Shall we invite Dr. Pao-Yu Chen again to do a lit review?
Okay, thanks, Dr. Chen. So the stage is yours, and you're going to tell us about why we use caspofungin, and then we'll talk about diagnostics a bit later. Thank you.
Okay, thanks. So I'm going to have two discussion topics. One is regarding trends, manifestation, and treatment outcome of invasive fusariosis, especially in hematologic patients. And the second topic is endogenous Fusarium endophthalmitis. For the first part, we can see two trend lines from Spain nationwide data, and the other data is from MD Anderson. The study period are more than 15 years, and we can see the trend are all increasing, even among those patients with non-neutropenic status in Hispanic data. And for the risk factors for invasive fusariosis of hematological patients, acute leukemia in induction chemotherapy have a high risk for IF as well as invasive aspergillosis, especially those with prolonged neutropenia, or some patients indicating that active smoking. And for allogenic transplant recipients in the pre-engraftment period, profound neutropenia, those receive cord blood stem cell transplant, and those with ATG in condition regimen are all high risk. So for our patient, there are two risk factors. One is profound neutropenia, and the other is ATG in the conditional regimen. But after engraftment, the corticosteroid or other immunosuppressant for severe GvHD or CMV reactivation will be the risk factor for those patients. And as we discussed in the first part, when the present of skin breakdown at the site of onychomycosis of interdigital intertrigo should increase the alertness as our patient. And I think this data is very interesting because from different cohort, the hematologic patient had a higher proportion of disseminated infection shown in a light blue bar. And some of them have fungemia ranging from 20 to 40%. On the contrary, non-neutropenic patients, including solid organ transplant recipients, most of them had pneumonia or cutaneous infection. Only few of them have fungemia or dissemination of invasive fusariosis. And this time trend is generated by the paper from MD Anderson, a study from 1998 to 2021. They quartiles the study period. As the treatment progress and supportive care become better, the patient had relapsed or refractory leukemia at diagnosis of invasive filariasis increased. And also, the breakthrough infection increased during this time period. So, because these are indicating poor host conditions, which will contribute to poor prognosis of invasive filariasis. And we can see that during the filariasis infection, the neutrophil recovery rate declining during the study period. And more patients had active leukemia even after diagnosis. Of note, the mortality rate is only numerically increasing rather than statistically significant. But I think all of these data suggest that a poor host condition that we are facing today. And for the MIC, as panelists discussed previously, we know that Fusarium solanaris species complex has a higher MIC among all antifungal agents compared to other Fusarium species, especially for the azoles. And I didn't review the latest data about phosphologetics and the olefin, but based on the literature, we know that for the olefin, maybe Fusarium aspirin had better lower MIC, but for the solanaris species complex, the olefin MIC still remain high. And in Taiwan, we only had olefin study for invasive aspergillosis. We don't have any clinical trials about phosphologetics. We also try to contact compassionate use of phosphologetics in Taiwan in maybe last 2 years, but we cannot get any assays for compassionate use for phosphologetics by contacting the pharmaceutical company. So in our situation, when we face invasive filariasis, we need to use combination therapy rather than the new drug in clinical trial or conventional status. And this is the global guidelines suggest voriconazole or amphotericin B as primary therapy. Maybe a combination of these two agents can be primary regimen. For the primary therapy, the third antifungal agent, including candin or terbinafine, are proposed, but the timing and the drug and beneficial population for the third combination remain unclear. So this is open to all panelists to give a comment. And I can show the MD Anderson data for the combination therapy. We can see all of them are lipid formulation amphotericin-based combination therapy. And the second drug is triazoles, including voriconazole, posaconazole, and isavuconazole. And for them, the third combination are all terbinafine. They don't use echinocandin as the third combination. And we can see the survival proportion between days and between these two groups. We can see combination therapy had a better outcome numerically, as well as the patient received GCSF. So maybe the third combination agent can be used as terbinafine, and the efficacy of caspofungin or other echinocandins will be further explored. And for the predictors of days at day 42 in MD Anderson cohort, there are no role of treatment related factors. Only neutrophil recovery had significant protective effect for the patient. So this is my first part of discussion. So we can have any discussion about triple combination or any other interesting topic about this part. Thank you. Professor Chen, I can hear you.
Sorry.
Sorry,
Pao-Yu?
yeah. I think we will go on to the next talk and have a general
Yep.
discussion at the end. I would ask the attendees perhaps to put your questions into the chat, and Banhok and I will do our best to collate them and not forget to look at the list at the end. So thank you very much, Dr. Chen. I will now invite Dr. Pei-Lun Sun, who is going to give us a talk on the pitfalls of diagnostics. Dr. Sun is the attending physician and associate professor in the Department of Dermatology at the Chianggun Memorial Hospital, Linku branch. Thanks very much. In Taiwan.
Thank you, Sharon. Can you hear me?
Yes.
Yes, okay. So let's quickly have a review of the usefulness and pitfall of laboratory diagnostics in invasive fungal infections. So for the laboratory diagnostics, we can have many methods. However, the most commonly used are microscopic examination and fungal culture. And for diagnosing IFI, we usually use microscopic examination with or without stent. And for fungal culture, the most common specimen are from either fresh tissue or blood. So this table summarize the commonly used methods I just modified from the manual of the clinical microbiology. And the KH preparation is quite common and easy to use, and it is our routine work in dermatology. And this is a cleansing agent that can soften and increasing the specimen and makes the fungal element visible. And you can see the time required is from 5 minutes to 30. So this is very operator dependent and also depend on the specimen, whether it is easy to handle or not. And we can see directly the hyaline or pigmented hyphae in the specimen. Sometimes we can use charcoal white to enhance the cell wall to make it easier to see. So the time required is much shorter. However, we need a very expensive fluorescence equipment, so it is not always available for routine use. And another specimen type is alcohol or heat fixed samples. So this specimen can be stained with grain stain or Giemsa stain that can highlight the fungal elements. There are also some limitation for each method that lists in the comments. So there's not a perfect method to do all, but I think the combination of them can increase the sensitivity. So this figure nicely illustrated how to do the direct sampling and staining with the Giemsa stain. So it's very easy to follow, and we can try in our clinical use. So let's have now that our topic is about the fusarium infection, so let's have a look at how this hyphae see in the KOH preparation. So the figure here shown, you can see the fusarium is light pigment, non-pigmented fungus. So the hyphae is hyaline with some different shape, and sometimes they have like some conidia-like sporulation, and they have septum, and they have branching, and this shows adventitious sporulation. I mentioned that later. And sometimes you can also see some swelling of the hyphae, chlamydal-like structures, such as shown here. And for the angle of the branching, you can see Fusarium can present either as 45 degree branching like that in Aspergillus, and also can have almost 90 degree of branching. So it is no way to say this is Aspergillus or Fusarium. And this picture also show you how bizarre the Fusarium hyphae can be. They can show some ridging at the border and frequent branching like the picture shown here. So how about this one? This is just a hyaline hyphae and quite monotonous shape. So do you think this is Fusarium or not? So this is quite different from the picture shown previously, but this is Fusarium. It is proven by culture, so it can be, the shape can be vary so much. So how about this one? You can see the many strings of chlamydal spore, very thick word here, and also some thin hyaline hyphae is shown here. Do you think this is Fusarium or not? This is fungus we just talked about. This is Pseudosporin epiospermum by culture. So how about this one? You can see many yeast cells here and some budding shown here. So is this Candida or Fusarium or anything else? So this is actually this is Purpurean lilacinum. And this one you can see this is just like a unilateral budding like that of the Malassezia. And you can see the fission here just like that of Pteromyces manavii. However, this again, this is Purpurean lilacinum. So when you check the other area of the sample, you can see examination. It can tell you that there is a fungus, but never tell you what it is. Okay, so coming to the blood culture, we usually use a fungal culture bottle rather than just plating the blood on the plate. I think every lecturer will do blood culture in this way. So we use fungal bottle and acceptable sample including blood and sterile body fluid. So we put the bottle in the machine, and when fungus grow, the machine alarms. Then we take it out and take out some for microscopic examination and some for subculture on the solid base culture media to for the further identification. So this is one case of what we can see from the blood bottle, and you can see under the gram stem, the fungus hyphae stand positive, and this is a MML patient. And according to, based on the original description, they send 3 sets of bottle, but only one of them grow the fungus. So they say it is a limited sensitivity of blood culture to detect disseminated fusariosis. And this is another case. We can see almost the same pattern of branching hyphae. And there's a hint here. In regard to the fungal hyphae, you also can see a reniform spore we call conidia here. So this is a great hint to us that maybe this is a Fusarium, and after the culture, this specimen grows Fusarium oxysporum. So we just talked about the serum galactomannan test. This is a review by Nucci, and he compared fusariosis and aspergillosis. So positive serum galactomannan can be seen in both invasive fusariosis and aspergillosis. So the positive rate is almost the same. And for the fungal bottle to grow, it says that usually take 1 to 4 days. The mean days is 3 days. So in comparison with other fungi, Fusarium grows relatively rapidly. So this is a very important publication that mentioned about the about the yeast form of the in the blood culture. So in this case report, the patient has initially the fungal bottle grows yeast form fungi only. But it takes, in case one, it takes another 2 days, and the second case, it takes another 5 days to grow the filamentous structure in the fungal bottle. So the author says that both cases highlights the fact that fusarium can grow as yeast-like structures in the blood, causing a delay in diagnosis. This is very important. So we should keep the blood bottle and do a serious observation to see if there's any growth of the hyphae. So coming to the histopathology, we use FFP tissue, and we usually stain with PAs and GMS to highlight fungal elements. But under the microscope, can you tell us which one is fusarium, which one is not? So actually, the upper one is Aspergillus, and the lower one is fusarium. But their branching pattern is almost the same. So just a very little differences in their shape. So actually, it is a little difficult. So this is another case. Which one is fusarium, which one is not? Actually, the upper one is fusarium, lower one is scedosporium. So they look so much alike. So we must be careful interpreting the histopathology results. So this is a iconic paper that that dermatologists, histopathologists want to summarize some clue, can tell us whether this is fusarium, Pasteuromyces, or Acremone, or other fungi. So they found that there is a very interesting presentation of so-called adventitious sporation. That means the forming of spores in the tissue. So in their review, they found that all cases with Pasteuromyces infection and Acremone infection has adventitious sporation in the tissue, and 7 out of 10 cases of fusarium infection have similar structure in the histopathology. So after this paper, many people take adventitious sporation as the key presentation of invasive fusariosis, but they forget that Pasteuromyces, so now we call it Purpureal cilium lanacinium, and the Acremone also can have this presentation histopathologically. Why this difference is so important? Because for Purpureal cilium lanacinium, the MIC, the infiltration MIC value may be much higher than that of fusarium. So if we put on the infiltrates B, there is no benefit to patient treatment. So another paper in 2004 that published that scedosporium infection can also have a adventitious sporation as their histopathologic presentation. So we should keep in mind that not all adventitious sporations means fusarium. So make a short conclusion that microscopic examination of fresh tissue or fungal culture bottle provides clue to diagnosing pathogens, including fusarium and also other molds and yeasts. The morphology of fungi in the fungal bottles may change with time. This is very important. So fusarium can initially present as yeast in blood culture, but later in mold form. Adventitious sporation is a character of fusarium infection, but not pathognomonic. Pathology provides a clue to the diagnosis, but cannot confirm the entity of the pathogen unless a specific feature is noted, such as the spheria in coccidioidal mycosis, but it is not the case in hyaline mold infections. So timely diagnosis and initiating effective antifungal treatment are important in managing IFI, especially in immunocompromised hosts. So physicians should be more aggressive in the isolation of the pathogens. So thank you very much.
Thank you very much, Dr. Sun. Are there any, that was very enlightening, and I think the concept of adventitious sporulations important, and it's frequently an exam question, at least in Australia, as to why you get fusarium in blood and why you get lamentaspora in blood and why you do not see Aspergillus or Scedosporium or Mucorales in blood. And it's all to do with the adventitious sporulation and the yeast-like form. So we would, I think Fusarium would be probably our commonest mold that grows in blood, and followed by Lamentaspora, but we rarely see anything else. Okay, so we may take questions. Banhok, I am trying to access the Q&A. I can only see.
Yeah, I think someone wants to ask about molecular detection. Probably we can direct that to Pei-Lun.
Yep.
Yes, for molecular diagnosis. Yeah, for Fusarium, we usually use TIF1 alpha and RPV1 or 2. Yeah, ITS discrimination power for ITS is relatively low. So we usually combine at least TIF1 alpha, I think. It is shorter and easy to PCR, and you don't have to use inner primer to do the sequencing.
Thank you. You didn't cover susceptibility testing, Pei-Lun. You want to say a few quick words? And there's also been some comment, at least in the clinical literature, that for Fusarium, the correlation with clinical success may not be so good. But I'd like to hear your thoughts, Dr. Sun.
You mean the
susceptibility testing of Fusariosis?
The MIC is all very high. Yeah, so when I see the results, I really don't know how to interpret it, because everything is quite high and there's no clinical breakpoint. So as for amphotericin B, the range is quite big. So we don't know which. I think we should have a good consensus on the breakpoint, especially at least the species complex label, so we can know which drug to use. So for example, amphotericin B MIC equal to 4, do you think it's susceptible or not? Or if it becomes to 16, do you think it's resistant? I don't know. Yeah, so I think because the case number is so low, so small, so I think we should accumulate more data on this and along with the clinical outcome. Yeah, I have good comments on this, sorry.
Do you use UCAST or CLSI, or
Here I use CLSI.
you use CLSI?
CLSI, yes.
There is another question in the chat. Banhok, shall I ask that one?
Yes, please, please.
Okay. It's a question from Meti. Do you have any comment about blood cell infusions and hyperbaric oxygen therapy for fusariosis? So I'll ask one of the panels. Yee-Chun? Blood cell transfusions and hyperbaric oxygen therapy.
Oh, personally, we don't have this kind of experience.
Okay.
I
Right.
suppose he means granulocyte
Jasmine?
transfusions, is it? Maybe MIT
No,
means.
he means blood cell infusions.
Oh,
I guess it could be white cell infusions. Yeah.
If profound neutropenia in disseminated severe invasive fungal infection, leukocyte transfusion is one adjunctive therapy.
yes.
Yeah, it will. Yeah, but as many of these kind of patients really have prolonged the profound neutropenia, but not this patient. They already engraft and recovery. So this is the reason why I ask all your opinion regarding the optimal dosage of liposomal, as Dr. Sun Pei-Lun mentioned. And but clinical trial is very, very difficult to make a conclusion regarding the how to interpret and the MIC to guide the dosage of liposomal amphotericin B, although we know this is concentration dependent. So higher MIC means we need higher dose. But how to incorporate all these PK/PD parameter to guide our optimal therapy. It is what we think about, because clinical trial really interpret it. So accumulate data cannot make the association, make a conclusion regarding the association or MIC and the clinical outcome.
Yeah, I think we just don't have enough data.
Yeah,
I agree. Well, you'll need to do a very nice PK/PD study, and think about, I guess you'll need to do it in an animal model first if it hasn't been done. I don't think it has actually. The dose escalation, like we have for mucormycosis. There's more data for that, but I don't think we have that data in fusariosis.
Okay, there's a question here. I'm not sure what the person is getting at. How can we make dependable in silico tools for the early detection of fusarium or other difficult fungi? Dr. Sun, would you like to try? What tools do we have at the moment? Is Dr. Sun on? I think Dr. Sun did cover some of the basics that we should all adopt when faced with a possible fungal infection. And the presenters already went through some of those things. So always try to get a specimen and always make sure you do a fungal stain. Dr. Sun went through all the various types of stains that could be tried, like cultivar, KOH, and I think it's a step that you shouldn't skip. And then always culture it. Try to get blood cultures. Skin lesions are not specific. Sometimes it's candida. Of course, they're smaller. Sometimes it's fusarium. They tend to be a bit larger. But really, it's worthwhile depending on the setting and the host. Sometimes it's tularomycosis, which can also appear in blood cultures sometimes. So my feeling is that we're not there yet, but we should not skip all of these basic steps. The other part of Dr. Jane's question, the development of resistance against a particular antifungal on exposure to a different antifungal. What's that mean? Does anyone want to try?
Well, certainly development of resistance to azoles can and often is pan resistance to azoles because of the common mutation. Generally, there are different mutations for different classes. Professor Chen, did you want to make additional comments?
No more comment, because there's a very heterogeneity in the background of the function and the drug and the exposure and the some environment factor. So yeah,
I mean, I think I get now what the person is trying to drive at. Yeah, if you are exposed to fluconazole and then you say you get a resistant Candida tropicalis, it's likely to be pan-azole resistant. I mean, that's but often, but not always, you can salvage the situation, say, with an echinocandin. But you would have to do the sensitivity to know which one to choose. Of course, in the empiric setting, you change class. But if you want to know, you've got to get the full susceptibility profile. I hope I've answered the question. Do the panelists agree? I mean, that's how I would look at it.
I think they would agree with you, Van Hoek. I think the issue is cross resistance. So within a class, luckily, we don't see resistance to another class that develops so easily with use of an antifungal for a different class. But I had difficulty honing in on the meaning of the question, and I wonder if it also relates to all these problems that we've had with, agricultural use of azoles, agricultural use of olorifim-like drugs, with the theoretical concern that it might give rise to clinical resistance when olorifim is used, but that's another topic,
Yes.
another day discussion. Yeah. I hope, Dr. Jane, that does answer your question. Is there another question, Bob?
Gimsa,
Yes.
yeah, it's
Yeah.
we can direct that at Dr. Sun. Is
Yeah.
Gimsa meant for only particular moles?
Yeah, I can answer this question. Actually, I cite this from our friend Retinal, her publication on the Gimsa stain. In his publication, he can identify. He can stand Histoplasma capsulatum, Cryptococcus neoformans, Taramyces, Aspergillus flavus, Candida tropicalis, and Malassezia fungi. So I think maybe Gimsa stem is more useful than we thought. We can try different kind of fungi. Yeah. So if the audience is interested, he or she can check the publication by Retinal.
Yeah, that's Dr. Retno Wayuningsi from Jakarta.
If I may, could I ask the presenters, both Dr. Chen's from Taiwan, a question regarding the use of high dose emphysome for the patient? We have had very bad experiences using prolonged and high doses of emphysome, even at 5 milligram per kilogram. How did your patient fare with 10 milligram per kilogram?
We in past more than 10 years, we have some severe cases. We start to use a very high dose, 10 milligram per kilo per day. For example, for Aspergillus endocarditis before operation, but immediate after operation, reduce the fungal load. We reduce back to 5 milligram per kilo per day. And but the more we use, we should still should be very careful regarding the drug-related adverse effect regarding the azotemia, electron imbalance, and others. So need to be careful. But for this patient, severe immunocompromised disseminated and CNS involvement, although we didn't see a big fungal lesion, but we need to think about the CNS penetration. So we give the highest acceptable highest dose, but we don't know how when we can de-escalate the dose and to balance the benefit and the risk. So this is a reason why we present this case, and yeah, that everyone of us we need to think about. And as everyone you point out, the fusarium has very high MIC, and during recent outbreak in United States and most Mexico, there's a very difficult, especially involve CNS. So we really need a novel new drug with different class, different mechanism to solve this kind of issue. As fusarium is a worldwide distribution, and we our patient very likely, very difficult to avoid exposure. This is our concern. Yeah.
Thank you. And, maybe I forgot. Did the patient's neutrophils recover, or so was this dissemination drug failure, or was it actually failure of neutrophil recovery?
Yeah, neutrophil recovery. Neutrophil recovery and engraft. So the hematitis is success, but however, still very poor outcome. So we need to review and refresh anything we can do better.
Okay.
Yeah.
Very, very difficult problem. It's, one of the infections that you really don't want to see. This filamentous such kind of two dreaded infections, and it always is very humbling to think about your experiences with these patients. Anyway, excuse me.
Okay, I think there are no more questions. Are there any more here? Yeah, okay, Dr. Jane is quite happy with our answers, Sharon.
Yeah, okay, that's great. Thanks, Dr. Jane. Okay, well, we may finish early then. So
Yes.
I've been very remiss. There's been a housekeeping detail that I forgot to mention. This whole webinar will replay at 1 p.m. Hong Kong time and Singapore time tomorrow. That is 4 p.m. for those that live in Sydney. And it will be through the AFWG online channel via YouTube. As to how to access, contact the AFWG Secretariat because she'll be able to give you far better advice than I can. So it just remains for me to thank our speakers and our panelists. Thank you for giving up your time. This will be the last webinar for the year, and the next one will be in February 2025, and ANZMIG will organize something. So I'm looking at Caitlin. We've got some work to do. So thanks very much and have a great evening.
Yes, thank you very much, Sharon. Thank you to all of you for listening. It has been very educational for both AFWG and ANZMIG to organize these webinars. And yeah, we hope to continue in 2025 and beyond. So as you wind down, have a good holiday period, have a good Christmas. Thank you and bye-bye.
Okay. Bye-bye.
Yeah.
Thank you.
Thank you.
Thank you.
Bye-bye.
Thanks, Banhok.